पूरा इसमें जूम पे ही हो रहा है सर, पता नहीं ये इंस्टीट्यूट में सारा वही। सर ये वाला मैं तो उसी में डाल देता था।
अच्छा नहीं, मैंने उसको फिर बाद में और मॉडिफाई कर दिया ना।
अच्छा कोई नहीं,
वो बाद में ना लास्ट में करना अगले साल के लिए।
अच्छा ठीक है।
अच्छा, इसमें न्यूट्रिशन कॉन्फ्रेंस होगा, यही है ड्राइव?
अरे इसमें वैसे मैंने चेंज नहीं किया सर।
न्यूट्रिशन कुछ है, हाँ ये है न्यूट्रिशन सेमिनार है। इसको खोलो जरा, क्लिक करो। ये न्यूट्रिशन एंड सर्जिकल सेशन, इसको यहाँ ले आओ। बस इसको बंद कर दो और ये निकाल ही दो। चलिए अब आप लोड कर दीजिए। अच्छा, ये स्क्रीन में नहीं आएगा?
नहीं सर, इधर ही बैठ के करना।
ये तो इसमें नहीं आएगा, इसमें ही आएगा फिर, क्योंकि शेयर स्क्रीन होगी ना। बेकार है पढ़ाने का, वो बेकार है, वो फ्रॉड है, फ्रॉड है। एक्चुअली क्या उसने ये होता है ना, वीडियो सो जाता है तो बैठे भी पोस्ट लंच सेशन से बैठे सोने को। लोग आ गए या क्या? यही वाला है?
हाँ जी
जो मैंने लोड किया था?
जी जी
ये पक्का?
हाँ जी
अच्छा।
आपका नाम हो
हाँ नहीं, वो नाम तो सभी का है
सर मेरा
BBE रहेगा
ओ इसमें करेक्ट कर दूँ अभी?
हो जाएगा सर। हाँ सर एग्जिट कर दीजिए।
अच्छा ये पता नहीं कैसे गलती होगी। ओके अब क्या करना है? अच्छा कोई आ गया है क्या?
वहाँ दो बच्चे
3 आ गए।
बोलते जाएंगे
कितना है टोटल में?
100
तो बहुत ही कम है।
नहीं अभी करेंगे करेंगे करते जाएंगे
अच्छा इसमें ये एडजस्ट करना पड़ेगा क्या सर का?
नहीं कुछ नहीं
नहीं वो
पूरा सर
कुछ वो नहीं आएगा।
एक बार देखने के लिए।
बस ये वही आएगा जिस लाइन खोला था ना आपका
हाँ
नहीं, वो तो
आप
शायद
वो जा रहे हैं लाइन
अभी ऑलरेडी स्टार्टेड।
F5 से
एक बार चेहरा तो दिखता है ना फर्स्ट में।
2 ही हैं अभी तो।
बढ़ते जाएंगे
डायरेक्टली शेयर कर देगा स्क्रीन आप।
हाँ डायरेक्टली शेयर कर
एक
दिया।
बार सर का मतलब स्टार्टिंग से मतलब उसके बाद।
इसको अनशेयर करें जरा पहले।
हाँ मैं भी बोलूँ
कहाँ थे?
इसका कहाँ गया? इसको माइनस करो, इसको काट दीजिए सर बंदे को।
इसको
हाँ ये आप आ रहे हैं।
ये कर दें।
हाँ मतलब आप दिख रहे हैं हम लोग
They can see ना?
अनस्केयर। हाँ
ओके इसमें चैट है।
you can see your screen।
ये वाला चेक किया
ये वाला चैट।
ओके कहाँ यहाँ पर आएगा? नहीं मैसेज एंटर ये मैसेज। ओके
माइक्रोफोन इसमें कर दीजिए। अपने आप म्यूट क्यों हो जा रहा है?
म्यूट अनम्यूट करिए माइक। कहाँ से होगा?
ये वाला इधर इसके ऊपर से।
ये ओके गुड आफ्टरनून। कैन यू ऑल हियर मी? यू कैन टाइप। I can hear you saying something, so I assume that you are okay with me starting the seminar today. Okay, let me start with welcoming the only student who is available with us now, and we will have to start the seminar, otherwise we will get delayed and we will have problem in completing the whole process of the seminar. First of all, let me welcome you to the seminar. Let me also wish all of you a very happy new year, since this is my first meeting with you. I hope that we had met in the last year as well, but I do not recall having met any one of you, and I hope that in this year that we will all be able to meet, and we also have some classes in person where you can get an opportunity to see patients, and I can get an opportunity to guide you in clinical surgery. So let me start again with a welcome. My colleagues in the seminar today will be Dr. Devesh Bhoi. He is an associate professor in the Department of Anesthesia, and he will be focusing on a major segment of the seminar. Dr. Richa Jaiswal from the Department of Nutrition will be joining us later, and she will also be covering a major portion of the seminar. Now I will welcome you all and state to you the learning objectives of today's seminar, and these are namely the assessment of a nutritional status in a patient who is there in these wards in surgery. To calculate the nutritional requirements of a patient who is either going to undergo an operation, who has undergone an operation, and who is in our post-operative care. Methods of nutritional support that we employ for our patients, and the indications and complications of enteral as well as para-enteral nutrition. Now the whole seminar is going to be divided into several segments, and let me just start with the introductory slide. Now I must tell you that just like today all of us had our nutrition, a hearty lunch I hope, and then we have come for this presentation, and I hope that you have also done the same. The same is essential for our patients in surgery, and therefore determining the optimal nutritional status of a patient is essential if you want that your operation in a particular patient should have a favorable outcome. We will have to identify the nutritional deficits that he may have either in the pre-operative period or in the post-operative period, and then we have to provide optimal nutrition for him, which we have to ensure that he is also able to consume. Attention to nutrition overall will help to minimize the morbidity and the complications in a patient who has undergone an operation. In recent years, there is much stress on early feeding of a patient. Somewhere in between we will touch on this topic also. In the current situation, we have availability of parenteral nutrition for our patients, and in fact I think in surgical terms this can be called as the eighth wonder of the modern world. Understanding of normal mechanisms for safe and early recovery of the patient from a surgical condition. This is very important, and the normal mechanisms is what one of my colleagues is going to touch upon. Now, as we go ahead, let me give you a brief that the normal metabolism and in disease will be touched upon by Dr. Devesh Bhoi. I will cover a portion of assessment, management and enteral nutrition. Parenteral nutrition in our patients is going to be taken up by Dr. Bhoi again, and Dr. Richa will come at the end and she will discuss metabolism in obesity as well as the several diets which are available with us. Now, having said that, I will request my colleague Dr. Devesh Bhoi to come and discuss normal metabolism as well as metabolism in disease. Dr. Bhoi, please.
इसको मिनिमाइज कर सकते हैं? हाँ.
तो सेम ही है उनका कवर ना, ये वाला मेरा वाला है,
This one is not.
हाँ ऊपर वाला है.
First
first of all, again, I welcome you all for this first academic section of this year. Happy New Year to all of you. I hope I'm audible to all of you. Let me just okay. So, as sir has already told regarding the nutrition part in patient we are normally dealing at surgery or the patient undergoing surgery. So it is one of the vital component that should be taken care of along with the disease per se. Suppose if a normal patient suppose eating a breakfast, a lunch or a dinner and all everything, okay, so suppose the patient has come for a disease process or undergoing a disease process, so at that time the requirement of the nutrition, it should be also taken care of properly, effectively, so that the ultimate outcome of the patient will be better for the sake of his benefit. Okay, so I'm just going to touch upon a little bit of normal metabolism. Now I'm not going to go into detail, just salient features, and I hope it has already been taught to all of you in biochemistry in detail. So if you see a normal metabolism, basically if you see a nutrition part, that is a combination of, if you see the metabolism, so basically our body is fueled by some of the nutrition. Okay, so the body is, if you tell it is a vehicle, it needs fuel for its running of the system and all. Okay, so once the body gets its fuel in the form of different food or nutrition, that is your in the form of carbohydrates, proteins or fats, so basically all the foods is having some part of this element. So these undergo basically different biochemical changes and sort of undergo this process of metabolism that lead to energy productions, and at the end, if the energy production is adequate and all, of course the body is going to have some work, or you can execute some of the muscle work and also daily systems work. So energy is needed for that. So whatever food you are eating, it's basically metabolized to provide the energy. Okay. So if you see, okay. So if you see the carbohydrate metabolism or glucose metabolism, glucose is the principal products of carbohydrates. Okay, and it is stored as your glycogen in liver and muscle. There is a process called a glycogenesis in that form, and it is stored in that way. And of course, it is stimulated by insulin that promotes your formation of glycogen. And at the time of need, the same glycogen is break down to provide glucose for the production of the energy, and that is a process called a glycogenolysis. So basically this process undergone by stimulated by insulin is a glycogenesis or a glycogenolysis. So if you see the glucose, blood glucose, it is in the liver, it converted to a glucose 6 phosphate, then subsequently glucose 1 phosphate, or a uridine diphosphate glucose. It is a 4-step process. At the end, the glycogen is produced and that is stored. Okay, and the reverse, if you say, it is not so simple. Again, it undergo a enzyme that is called a phosphorylase that converts glycogen to glucose 1 phosphate, and subsequently the phosphatase converts 6 phosphate to glucose. So the glucose is produced at the time of need, and that is the process that is basically stimulated by glucagon or epinephrine, that is a part of the sympathetic stimulations and all. Okay, so this process undergoes in the body when there is a requirement, whether it is a tissue injury or a disease process. Okay, so if you see the different stores in our body, so if you see the carbohydrate stores, again it is stored as glycogen and all, but at the time of need, basically if mostly the liver glycogen that is utilized, but the storage is not so big and it lasts hardly half a day. Okay, the next stores, if you see a protein store, the body is a big or a large protein stores, it's very relatively large. Okay, however the protein, basically if you see, it all is having a specific purpose for that, whether it is an enzymatic structure or a contractile function. So if there is any loss of any protein in the body, that represents, obviously there is a loss of an essential function. So this is basically the requirement of the protein in our body. So if you see, as you know, excess of carbohydrate, suppose there is excess of carbohydrate in proteins, then subsequently is stored as fat. Okay, and if you see the energy productions by the proteins and the glucose, they are basically inefficient source of energy. If you see relative to its weight content, it hardly provides 1 to 2 kilocalorie per gram of weight. However, if you see the fat, that is a very rich source of energy, that is around 9 kilocalorie per gram, and it's stored in an anhydrous state. Okay, and the carbohydrate stores are basically reserved for production of the high energy phosphates during anaerobic metabolism. So these are the process of energy productions if the different type of nutrients in that way. So what happens basically if you see a glucose metabolism, you have two type of metabolism. As everybody knows, they are yielding of around 38 ATP if it undergoes aerobic, your oxygen dependent, there is aerobic pathway or Anaerobic pathway. However, when there is a deprived of oxygen supply, that is anaerobic pathway, it forms only 2 ATP or 2 energy molecules, and also along with that there is the formation of the lactate. Okay, so if you can see this aerobic and anaerobic metabolism, if it's a combination of glycolysis that lead to glucose and converted to pyruvate, but in case of anaerobic or that is oxygen deprived state, the pyruvate is converted to lactate. So basically lactate is produced during your oxygen or hypoxic state in that way, and there is less production of energy in that way. Okay. So if you see this figure, I think this is a beautiful picture that is described. If you see it here, all the three, that is type of food nutrients, that is carbohydrate, fats and protein. So there is basically interrelations of all this element that lead to formation of your glucose, and subsequently they all three enter in the common pathway. So you must be knowing that is citric acid cycle, that is your Krebs cycle, that is the common pathway for all type of, that is whether it is a glycerol from fats or a carbohydrates, that is glucose or the proteins. Okay, and those proteins, that is basically your gluconeogenic. Okay, you must be aware of this term, that is gluconeogenesis, that is basically non-glucose molecules, they form the glucose. Those are the gluconeogenic, basically your, I mean, it is a molecule or lactate, they form the glucose when there is a need or there is a sympathetic stimulation in that way. Okay, so this next comes to, suppose if there is a stress or starvations. Okay, this normally happens again individual points. So if you see only liver glycogen is utilized in that way, that doesn't last long after this. So what next? Next is your protein metabolism. So what happens to the proteins in that way, the normal protein that we ingest? So it's basically, if it is large number of, that is amino acids, they are linked by peptide bonds, and if you see the digested proteins or what is own proteins, they form the amino acid pool. And what happens during growth or in that time, there is a positive nitrogen balance. That means the protein synthesis, whenever there is more and more protein synthesis, there is a positive nitrogen balance. Okay, and the alanine and glutamine, these two are the amino acids that can form glucose. Those are known as gluconeogenic. Whether it is a leucine, isoleucine, phenylalanine or trypsin, these are ketogenic or ketones. This amino acid, they form ketone. Okay. Same again, this the involvement of citric acid cycle in transamination or gluconeogenesis. If you see this form, your tryptophan or alanine, they undergo the transamination lead to pyruvate, and they of course still require, there is a oxidation that leads to energy productions, and subsequently these are interrelated metabolism of all the three. If it is the fat metabolism, basically the fatty acid, small lipid pools, that is fatty acid and derivatives. It's basically fatty acids and derivatives like triglyceride, what is a phospholipid or sterols. Okay, and if you see a triglyceride, basically the three fatty acids, they are bound by the glycerol. Okay, and if you see the fatty acids is there from the acetyl CoA, that lead to later on oxidation providing the energy, and lipid is seems to be a very rich source of energy, providing around 9 kilocalorie, as earlier I told you. This is the beta oxidation that lead to energy productions from the fat. So when there is a starvation, of course the majority will replace fat. Once your glycogen exhausted, then the stored lipids don't get utilized for the energy productions. However, the obligate glycolytic cells, these are the neurons, RBCs and leukocytes. They basically the purely obligate glucose dependent cells. They need glucose, and if you see the requirement, they need around 180 gram of for 24 hours. This glucose requirement of this glycolytic cells. Okay, that we have to maintain. Same, suppose there is a glucose already existed. Then what next? From where the glucose will come? Obviously, it's a gluconeogenesis. That means it's supplied to the proteins. Okay, and protein, where the protein will come from? Basically, this is the muscles. The muscles contain the more and more proteins, so the protein will be supplied by the muscles. So the more and more protein will be extracted from the muscles. That might lead to the muscle loss or loss of the muscle protein in case of starvation or prolonged starvations. Okay. Same the gluconeogenesis. Firstly, the liver is the active role in the gluconeogenesis, but later on, if the starvation is prolonged, kidney also start producing the glucose. However, at the same time, the nitrogenous products will be excreted and the load of kidney will be increased. Okay. If you see the alanine and glutamine, these are the main amino acids that form the gluconeogenesis. Okay. And on an average, there is around 60 to 90 gram protein loss in this process of the starvations. Okay. This is the starvation. As you can see, once after your glycogen is exhausted, the adipose tissue free fatty acid will be utilized. So at this time, the brain will start utilize the ketones for the because this need glucose. So the glucose will be created from the ketones. In that case, the fat stores will be utilized. So that's why if you see the administration of glucose, there is around 100 gram per day. What will happen? That means if the glucose will be administered along with the insulin, then there will be a protein sparing effect. That means you can save the muscle protein loss. Okay, because the insulin, they inhibit the amino acid release from the muscles. They try to inhibit the release of muscles. Okay, so the muscles wasting will not occur, and they also inhibit the extraction of the liver also. That means the insulin try to maintain the blood glucose level in that way. However, in case of diabetes, this insulin or the protein sparing effect is not there. Okay, so if the starvation is also prolonged, obviously the brain will start utilizing ketones because there is no glucose in that. Next comes to the surgery or any trauma or any sepsis. What will happen? So basically any surgery or a trauma, this is basically a body assault. That body respond in a variety of, there is a myriad of responses out of that endocrine or metabolic response, they exerted by the body. This is the first that is I think described by the Keith Burton and co-workers, and they describe in two phases basically. First is half phase and second is the flow phase. So if you see the immediate that the consequences of a surgery or a trauma or insult, the body tries to decrease the expenditure, energy expenditure. These are the immediate consequence of a surgery or any assault to the body. However, the late flow phase, in that case, there is compensatory or delayed compensatory phase. Try to body compensate for that. Okay. Again, this is also depend on the severity of injuries. So how the body, or in which the severity, mild, moderate or severe, in that way this responses is given by the body. Okay. So these are two: catabolic phase or anaerobic phase. The body has to undergo these two phases. So what do you mean by the catabolic phase? If you say the catabolic phase, it is also known as the adrenergic corticoid phase. So it also, you know that in physiology you must have seen that is a fear and flight, that is the flight response or the sympathetic stimulations. So the first, whenever there is a assault or anything, there is sympathetic stimulation. That is basically adrenergic and corticoid phase. The release of adrenal glands, your glucose or glucocorticoid. Those are the responses that body gives rise to. They basically try to balance, that is energy balance. How they want to balance? So obviously with increase in metabolism, there is increased requirement also. In the patient is febrile, suppose the patient having some sepsis and all in the febrile, and it has been seen that it normally 7% per degree of Fahrenheit temperature, their energy requirement increased. If you the increased catecholamines, that is the sympathetic stimulations, there is increased sodium permeability. and to energy is utilized for that transmitted ion potential to maintain. Okay, because there is sodium per minute increase, so basically the energy is required for that also, to maintain a transmembrane ion concentration, okay, for the proper body function. So if you see the energy expenditure in different trauma or different assault to the body, you can see the different percentage increase from the vessel energy expenditure. So if you see a sepsis and burn, they are the two major assault that has been found to increase the vessel energy expenditure in 79%, or in burns 40% burns it has been shown to be 132%. Okay, and that also lead to the urinary nitrogen excretion, because the more and more kidney is also involved in that metabolism. So obviously there is nitrogen products which is created. If you see the lipid metabolism in a surgery or in a assault case, what will happen? Of course, the sympathetic stimulation or the catecholamines, they induce your hormone sensitive lipase that lead to formation of the free fatty acid and glycerol. And this free fatty acid, this basically they try to make a source of energy that for the non-glycolytic cells. The glycolytic cell, and the glycerol will take part in gluconeogenesis. That gives to the glycolytic cells, so basically those energy will be supplied to them. Free fatty acid again is converted to the ketone bodies, and if you see during the stress and sepsis, basically this production is decreased. But in case of starvation, there is always increased ketogenesis and also oxidation of fatty acid for the production of the energy. If you see the carbohydrate metabolism, again during a sepsis or a trauma or a surgery, the body is show its effect by hyperglycemia. There is increased gluconeogenesis, because again there is impaired peripheral glucose uptake also. So all this mechanism lead to hyperglycemia. Sometimes that is a very poor indicator for the proper healing and all. So basically it is delayed or healing in that case when the glucose is not monitored or controlled adequately. Sometimes it has a deleterious effect. Okay, so you must know the normal metabolism when there is a assault or surgery. So it has a tendency that there will be perioperative hyperglycemia might be occur, and that's why in the perioperative period the sugar is again taken into control in an effective way, so that the outcome will be improved. If you see the protein metabolism, again there is the proteolysis. They generate glucose and also calories, that is energy production. So only 20% is utilized for this purpose. If you see the anabolic phase, okay, this is the second phase. First is catabolic, this is the anabolic phase. Okay, anabolic phase, again it might be an early anabolic phase, so it is a corticoid withdrawal phase, or the late anabolic phase. So in case of the cortical withdrawal phase, basically it is it might be take around a week times in a uncomplicated surgery, or it might take, suppose if there is extensive tissue injury, then it might take longer time also. And in that case, there is sharp decline in the nitrogen excretions, and they try to restore the nitrogen balance. And then this is the time the body used to make a positive nitrogen balance. That means it indicates a protein synthesis, weight gain, and muscle strength. And that's why the role of nutrition again takes a very important, because at this time you have to optimize the nutritional requirement of the patient, so that it take part in that protein synthesis or weight gain. Okay, sometimes again it's weeks to months also, depending on the depletion of the protein store or extent of depletion. So if the stores has already depleted a lot, in that case it might take time also. If you see the late anabolic phase, it takes, if the intakes exceed expenditure, it takes months to a year, because this is the phase where your tissue adipose stores that is restored. So in the early and the late. Okay, so I think the next part is will be covered by the Dr. Richa. Will you share that?
No, she'll come later.
Okay.
Yeah, so I will give the next part. Yeah?
Okay.
So you can.
So okay,
stop this.
yeah. So next, I think Dr. Chumbar sir will again describe regarding the nutrition assessment and all, and Dr. Richa will join us later regarding the metabolism and obesity. Okay.
आप इसको मिनिमाइज कर दीजिए
हाँ
सर, और मेरा वाला ऑन कर दीजिए. नीचे
ये वाला सर.
हाँ यहाँ से
नीचे यहाँ से नीचे ऊपर
Okay, I am back. Thank you for being with us this long. Now I am going to discuss with you the assessment and management of a patient in surgical wards, whether they are in the preoperative phase and frequently in the postoperative phase. I will also be taking up nutritional, enteral nutrition now, and later my colleague Dr. Bhoi will take up parenteral nutrition. Now the first thing is that what are the methods of nutritional assessment? Now, I'm so sorry. The methods of nutritional assessment are: number one, anthropometry. Now we have used the body weight and the loss of body weight over short intervals. This carries grave significance for our patients. How can I make it full screen? कैसे करेंगे? From current slide, no? Okay. Now, loss of weight over a very short interval carries an ominous prognosis. Frequently we use triceps and subscapular skin fold thickness. This is in fact used more often in pediatric patients than in adult patients. But this is a fair indicator of loss of body fat reserve stores. Mid-arm muscle circumference is a very good indicator for use in the community as well as a rough guide in the outpatients. This is a good indicator of muscle protein stores, especially loss of muscle protein stores. One more assessment factor that we use is creatinine height index. This is related to the muscle protein mass and it is normalized for height, and this is a better indicator of nutritional assessment in our patients. However, the commonly used ones in clinics are the triceps skin fold thickness and the mid-arm circumference. However, there are some drawbacks. There is no factor available that we can employ to correct for age, hydration status, or for physical activity in such patients. And there is a confounding in patients, especially in presence of edema, liver failure, or renal failure, or all states where the hydration status is more than what is necessary. Now I must touch upon what is called as the BMI, and most of you would already be aware of it, and it is given by the formula as mass in kg upon height in meter square. Now I think that this slide will explain it better, that this is a short screenshot of calculator net, and there are many such apps available for you to download, and where you will write the age of the patient, and in given slots you can enter the height, the weight, and it will calculate for you the BMI of the patient, or what is known as the basal metabolic index. Now you will find that on this particular scale it is given that the normal range lies between 18 to 25. I think it's a little lower for us at 23, and patients far below this are rated as underweight. Then above it is overweight, and finally entering in the zone of obesity. This is one of the most common employed methods of assessment in patients in malnutrition as well as in states of overnutrition or overweight and obesity. In the clinics it is often used by most of the residents as applications downloaded on their mobile phones. Now there are several biochemical methods that we adopt, and I will tell you about serum albumin and the others which are not so important, that is pre-albumin, transferrin. Now serum albumin is one of the most important talked about parameters in the wards, and you will find that the consultant, while taking the decision in regard to placing the nutritional status of the patient or planning a meal operation, especially where healing becomes most important, as in resection and anastomosis of bowel, that the consultant may ask, what is the albumin level of this patient? What can we do to increase the albumin level? And these factors are known to improve the outcome in such patients. Albumin has a half-life of about 20 days. It equilibrates slowly between the intravascular and the extravascular spaces. Now this slow rate of equilibration means that it takes about 7 to 10 days to equilibrate. So it is not an indicator of the immediate status of nutritional status of the patient. It depends on several factors, especially the rate of synthesis of albumin. If the intake of the patient is poor, the rate of albumin synthesis will go down. Albumin degradation, albumin losses, especially in urine from the body or through fistula sites, exchange of albumin between the intravascular and the extravascular space, and the volume in which the whole albumin is distributed. So even though it's a commonly used index of nutrition in the wards in clinical practice, there are many problems with this. Serum albumin is consistently altered in various inflammatory states, gastrointestinal diseases, cardiac and renal diseases, wounds, burns, and in patients with peritonitis due to increased transcapillary losses, increased degradation, and decreased synthesis of albumin. The other parameter is pre-albumin, which has a short half-life. That's why it may be a better indicator of recent nutritional status. However, it is also altered in renal failure and liver failure, and effectively overall it becomes an unreliable indicator. Transferrin is often not available and remains a costly proposition. Another parameter that you may observe clinicians often question is the status of immune competence of a patient, and this is measured by delayed cutaneous hypersensitivity, and it is indicative of very severe form of malnutrition. It is also altered in conditions like infections, chronic disease states like uremia, cirrhosis, and hepatitis. And in patients who are placed on immunosuppressants, steroids or warfarin. Now, a clinical assessment may be performed in such patients to identify the initial nutritional state and factors influencing progression or regression of nutritional abnormalities. The clinical nutritional assessment is a dynamic process. So you have to take into account the past, the current and the future status of the patient at high risk for future nutritional abnormalities. Clinical assessment must include a good history, a complete physical examination for various nutritional deficiencies. You also have to look for evidence of trace element deficiency or deficiency states of vitamins. Now, in our wards, we often employ what we call as subjective global assessment, a clinical method which is validated to predict nutrition associated complications. Well, it takes time and requires a skill, but overall it is an easy method of classifying patients. It encompasses historical, symptomatic and physical parameters to categorize patients into 3 groups. Now these groups are category A. This is composed of patients who are well nourished or who have only mild degree of nourishment and who has experienced weight loss and muscle wasting, but is currently eating well and is gaining weight. As an example, we can take a patient who has undergone a cholecystectomy. It's a short procedure. There is almost no muscle wasting or weight loss, and shortly after the operation, patient can be started on a normal diet and he is again on to gaining weight. Category B is moderate malnutrition. It is seen in a patient who has experienced moderate weight loss. As an example, we can cite a patient who has had multiple road traffic accident fractures and who is admitted in a hospital for longer than 2 or 3 weeks. He has continued compromised food intake and continues to lose weight, and there is functional impairment. Category C is of patients who have severe malnutrition. As examples, we can cite the case of a patient who has peritonitis, pancreatitis, or a patient who has intestinal tuberculosis. Effectively, a patient who has experienced severe weight loss and continues to have poor nutrient intake with progressive functional impairment and muscle wasting. Now we have to estimate the nutritional requirements of our patients. I am noticing that a lot of our audience is exiting, and I hope it is only for a very short nutritional break while we are calculating the nutritional requirements. Now I can say that the energy requirements, or rather the normal energy requirements, are met by non-protein energy resources, as Dr. Goi has already told you. And we have here with us the Harris and Benedict equation, which can be known as the cornerstone to understand basal energy expenditure in both males and females. taking into account their height and weight as well as their age. Now in normal patients, the non-stressed who are otherwise normal individuals, the basal expenditure is that of the resting energy expenditure. However, in patients who are surgically stressed, having undergone a procedure, or those who are bound to undergo a procedure or who have a chronic illness, the resting energy expenditure is far above than the basal expenditure, and the extent of rise above the basal expenditure depends on the type of surgical stress. In trauma patients, the use of exogenous nutrients is decreased, that is, they are not able to take food. Therefore, the non-protein caloric intake are about 1.2 to 1.5 times the resting expenditure, with nutritional, enteral nutrition, and about 1.5 to 2 times with intravenous nutrition. So that would be the factor by which you would have to increase the calorie delivery to these patients. In general, stressed patients should receive about 30 to 35 non-protein calories per kg per day, whereas non-stressed patients, that is, who would otherwise be classified as normal, should receive about 25 to 30 non-protein calories per day. So you have now a rough idea of how much nutrition to provide to your patient in the postoperative period. Protein requirements are calculated because the protein synthesis are dependent on the nature and the degree of insult and the prior nutritional status. So the daily requirements of proteins will vary in our patients from 1.5 to 2.5 grams per kg per day, and of course it's the equivalent of about 0.2 to 0.5 of nitrogen. There has to be a fixed ratio between the calorie nitrogen intake, and which is anywhere between 150 to 200 kilocalories for each gram of nitrogen. For all our patients, we will routinely supplement with vitamins and other essential factors. An average patient in whom the procedure, the surgical procedure is small, or patient recovers in the postoperative period early without any complications, vitamins and mineral supplementation is not required. However, in patients who are on prolonged enteral and parenteral nutrition, supplement vitamins and minerals are given. Vitamin K, vitamin B12 and folic acid should also be supplemented separately. Trace elements are always supplemented, as well as essential fatty acids. Now, as regards the routes of nutritional support, I will briefly touch upon the enteral route, and my colleague will later touch upon the parenteral route. Now, enteral route would imply through the stomach and the intestine, and it remains the preferred mode of nutritional support in patients in the surgical wards. It's the most physiological method. Remember, the liver is not bypassed, and the hepatic ability to take up, process and store food remains intact. Enteral route is safer. It's far more efficacious. And remember, the intestine acts as a barrier to maintain defense against intraluminal pathogens and toxins. Of course, the cost of enteral nutrition is also much less. Your meal in the mess would cost much less than similar amount of calories and proteins delivered through the parenteral route. The parenteral route is used in such patients where the gastrointestinal tract cannot be used, or it is insufficient for absorption, especially in a patient with a short intestine or short gut syndrome. And it can lead to disruption of this gut barrier function, leading to translocation of bacteria, gut endotoxins, and giving rise to septicemia. Now, majority of surgical patients do not require nutritional support because they are well nourished and healthy individuals who undergo an uncomplicated major surgical procedure. They have sufficient body fuel reserves to withstand catabolic insult or starvation for as long as a week. They require only adequate quantities of parenteral fluids, electrolytes, and a minimum of about 100 grams of glucose, or what we call as 400 calories, needed to minimize protein catabolism. Enteral nutrition is indicated in severe surgical stress and sepsis. In patients with surgical complications who cannot maintain caloric intake. In increased energy expenditure, enhanced catabolism, and rapid loss of lean body mass as a result of inflammatory responses, where gastrointestinal feeding is beneficial and is the preferred route of administration of nutrition. The routes that we use for enteral access in our patients, we decide depending on whether it is required for a temporary period or it is for permanent. And obtaining enteral access requires foresight, planning and skill. The nasogastric tube is used with the patient with functional gastrointestinal tract with very low risk of aspiration, and in a patient where it is required only for a short period. Similarly, for gastrostomy, you can have intragastric access through a percutaneous endoscopic gastrostomy, by open method, or fluoroscopic or laparoscopic guided techniques. Jejunostomy is one of the commonly used procedures in our surgical wards. It is used for long-term enteral access in patients with delayed gastric emptying or obstruction beyond the pylorus, increased risk of aspiration or reflux. Jejunal access remains the preferred route. We can have a jejunostomy which is performed as a Roux-en-Y or a permanent or a Witzel or temporary kind of jejunostomy. A jejunostomy may be performed by laparoscopic, fluoroscopic or by percutaneous endoscopic techniques. Feeding after a jejunostomy can be started as early as 12 to 24 hours or depending on the protocol. Now, the methods of delivering nutrition through the enteral route is by three methods. One is a bolus feeding. In patients who are alert, who have no risk of aspiration, you can give boluses almost up to 300 ml at one time, and they are likely to be absorbed without any risk of aspiration. Gravity feed is often used in children, neonates especially, where a bolus technique is not very tolerated and it is given as a continuous infusion. Mechanical pumps are sometimes used to deliver controlled quantities through the nasogastric tube. Now, nasogastric tube and gastrostomy feeding should not be given in a patient who is asleep or at night or carries a risk of aspiration. Sometimes there is a large residual volume in the stomach and this carries a risk of aspiration. Often the feeding through the jejunostomy may be followed by cramping, abdominal cramps and diarrhea, in which case we have to either reduce the flow or we have to decrease the concentration of the jejunostomy feed. In patients who have a high output fistula, intestinal fistula or biliary fistula, we can collect the amount, we can filter it, cool it, and then we can refeed it through the jejunostomy. Some of the complications which are seen in patients who receive enteral nutrition are aspiration pneumonitis, Other infections include sinusitis, otitis media, or in a feeding jejunostomy related to wound infections. Diarrhea may occur due to lactose intolerance, rapid feeding, or in using hyperosmolar formula. So you just slow the rate or you alter the diet. Some of these patients may demonstrate hyperglycemia, especially in patients who have diabetes. Hypokalemia and metabolic alkalosis may be rarely seen. Now, in patients who have severe hypokalemia, what we have, they may develop what is called as a refeeding syndrome. It manifests as severe hypokalemia and severe hypophosphatemia in patients with hypermetabolic states and severe malnutrition. Thank you very much. I think our strength has decreased, and just as my strength has decreased while speaking, but now I must ask my colleague Dr. Devesh to take over, and I hope that many of you who have had a nutritional break in between will return. Do recall that your patients who have been operated by you, who have good nutritional status and where the surgeons take good nutritional care of them, they will do very well post-operatively. I hope you will be with us. Dr. Devesh, please.
Okay, so I think sir has already told regarding
You take breakfast.
okay. I think the same thing continues.
वो है नहीं slide के अंदर.
हाँ.
I have removed those things. इसको minimize कर दो. हाँ, ये देखो.
Okay. So now I just came to discuss about the parenteral nutrition. So if you just go by the term parenteral nutrition, as already sir has told regarding the indication or use of this parenteral nutrition. So basically in those conditions where your gastrointestinal tract cannot be used, or it is insufficient for the absorption of the adequate nutrients, in those cases, so you have to depend on a IV line or bypass your enteral route. Basically that's why it's a parenteral route of nutrition. So in that case, the part or whole of the nutrition is administered through a IV lines or a central line. Specifically your it is preferred accessory that end up in that. And if it contains a hyperosmolar solution, that the combination of your carbohydrate, proteins, fats and other nutrients, this of course the combination of those two, how will requirement is calculated, that again will be Dr. Richard. So basically there are the hyperosmolar solutions. So if you see the proteins, so basically the protein utilized in your total parenteral nutrition, it's basically a mixture of synthetic origin and bacterial culture and also your hydrolysates. So at least 55% that is hydrolyzed into amino acids, and the rest are your dipeptide or tripeptide that not efficiently utilized. If you say the dextrose, that is hypotonic, that is basically non-protein calories is provided by that. So if it is required, there is a dextrose or amino acid formula. It might be a combination of those two, or in some cases it's lipid system with 10 to 20% of the dextrose. In that case, this protein is not there. So these are basically the combination of the total parenteral nutrition that is administered to the patient. If you see the fats composition, it is basically lipid solutions that contain your either your soya or sunflower oil, And most commonly also that is used is fish oil that contain your omega-3 fatty acid, and it has the immunomodulatory effect. And they are all combination of a mixture of the long and medium chain triglyceride. And you must take care that the ratio of the calories to the nutrition should be adequate. At least 100 to 150 kilocalorie per gram should be nitrogen, and there should be simultaneous infusion of the both non-protein calories and nitrogen. And in these cases might be there is chances of electrolyte abnormality in the form of hypokalemia or like that, which should be monitored and supplemented if it is required. So these things should be taken care of when the patient is on total parenteral nutrition. So let me tell about the types of total parenteral nutrition, the different types that is used. Basically, one is total parenteral nutrition, that means the whole nutrition is given IV. One is partial parenteral nutrition. In that case, patient is having some form of nutrition also taking in enteral route, however the partial is supplemented with the IV route or the intravenous route. Okay. And third is your home parenteral nutrition, that is I'm not sure it is, I think it not so, I think mostly in those cases in acute or chronic intestinal failure, I think in western part it is very common, because the patient cannot be admitted for the long and only for the parenteral nutrition patient should be admitted. In that case the parenteral nutrition can be administered at home, but in that case the family or those taking care of the patient should be willing to take the precaution, that is in form of the maintaining sepsis, maintaining the catheters, giving the different type of nutrition. So those things are a little bit of needed in those home parenteral nutrition. So if you see the administration of total parenteral nutrition, it always the insulin is supplemented to improve the carbohydrate tolerance, because the tendency of hypoglycemia is there with TPN. There is always a risk of hypokalemia, so it should be monitored and supplemented. The nutrition should be, obviously the potassium component should be there. It should be adequately supplemented and the monitoring should be done. In cases with major trauma and sepsis, there is chances of insulin resistance. So in that case, lipid emulsions are used than dextrose containing solutions. Again, the intravenous vitamin supplementation, almost the same thing. Also, Sir has told in the enteral nutrition, this vitamin supplementation again it is needed when the patient is on TPN. Intramuscularly given once in a week is a vitamin K1 or a folic acid that should be supplemented. The patient should be supplemented of these two. Vitamin B12, that's again it is should be administered intramuscularly once in a month. Essential trace element, again those patients on long-term parenteral nutrition, when they need the essential trace element, it should be supplemented to those patients. And last with the iron and magnesium, it should also be supplemented to those patients. Again, the essential fatty acid, basically those are the fat-free total parenteral nutrition. Those patients should be administered the essential fatty acid in that case. And those patients having specific your condition like your renal failure or hepatic failure, you have to modify. Suppose in case of a oliguric renal failure, in those cases that is renal output has decreased. So obviously in those cases the 40 to 45% dextrose solution with essential amino acid should be administered. And in case of a non-oliguric renal failure, that means the renal output is maintained, in that case both essential and non-essential amino acid can be supplemented. So in those case, however in case of hepatic failure, if you say, it should be the less of aromatic amino acids, because they might again tend to metabolize, and the hepatic encephalopathy might degrade, or neural transmission might be degrade. So in case of hepatic failure patient, the branch and amino acid should be avoided and the aromatic amino acid should be avoided. If you broadly indicate, you just try to number the indications. There are a variety of indications, and basically those patients, if you see in case of the newborn infants, basically any gastrointestinal abnormalities like tracheobronchial fistula, gastroschisis, or a massive intestinal atresia, in those cases the feeding cannot be done by enteral route. So it should be total parenteral nutrition is the answer in such cases. Patient with adult, that is short bowel syndrome, or a significant amount of bowel resection has been done in surgery, obviously the patient needed TPN. And the fistulas like enterocolic or enterovesical, enterocutaneous, If it is a high elementary obstructions like stricture or a CA esophagus, pyloric obstructions, so basically you cannot maintain a enteral route, so total parenteral nutrition is must to maintain the nutrition and also the depletion of the protein stores. Okay. Suppose in some cases after a prolonged major surgery, the patient has gone to prolonged paralytic ileus, so you cannot keep the patient a meal for orally or without any nutrition for long. So in that case again the total parenteral nutrition should be started in those cases. In some cases of esophageal dyskinesia of functional region, anorexia nervosa or inflammatory bowel disease, patient paraplegic, quadriplegic or some indolent liquid ulcer, in those cases again it is the nutrition that should be taken care of properly, and it might, the TPN helps in those cases. So let me say, describe the routes of administration. If it is a parenteral nutrition, if you see there are three different types of routes of administration. If it is intravenous, it might be through a, if I think you must, if you have gone to the wards or operation theatre area, you must have seen that the peripheral IV line is taken in a major vein, like your in the dorsal of the hand. So for the routine IV fluids, okay. So those lines can also be used for a total parenteral nutrition. Of course, in that case it might thrombose early, but it cannot be used for the long. The second option is your peripherally inserted catheter. So if you have, I'm not sure whether you have seen or not, it is basically again it is a long PVC catheter, or in some cases silicone made also. So it is basically entered through antecubital veins or your the cubitus, and the catheter is inserted. It's having a guide wire. Once the tip is adequate optimal depth has been inserted, the guide wire is taken out, and this is having a stopcock. So IV fluids can also be administered, and also the total parenteral nutrition can also be administered through this. So this again, it has you can maintain this line up to 2 weeks in those cases where you want to maintain this peripherally inserted catheter for the nutrition purpose. And the third option is a central catheter, that is a central venous catheter that normally placed can be through external jugular vein or a most commonly internal jugular vein. And if it is right subclavian vein or some left subclavian vein, and if it is placed in the subclavian vein, obviously it is a more favored location for a long-term access. And the catheter is placed this through major veins, that is central catheter, that is used for your administration of the total parenteral nutrition. So if you can see, this is a peripherally inserted catheter, just needle, its guide wire is emerging from the needle. So this is kept inside a sterile cover. So without touching the catheter, once you insert the needle in the antecubital veins, the guide wire is along with the catheters can be inserted, and once optimal depth is there, take out the guide wire and fixed it. So then your central line, again it's a it might be a single lumen or a triple lumen catheter. Okay, it's a Teflon coated catheter, preferred for the long term keeping of the catheter. This kind of line can be utilized for the IV access or in some VA, and it can be administered your total parenteral through this. Okay, so if you see the third or fourth option, another is your Hickman catheter. Again, this is one of the catheters that can also be placed for the long term. In this, the catheter is access to the same subclavian vein or intrajugular vein. However, this rest part is tunneled to the skin and fixed in that way so that it can be utilized for long term. Okay, so this is a silicone coated catheter or Hickman catheter. Again, there is an optimal depth is very important for such catheter. If you see the route of right intrajugular vein, the catheter should be around 15 centimeter. If it is through a right subclavian vein, of around 14 centimeter is needed for tip in the supra vena cava, 18 centimeter for the left internal jugular vein, and 17 for the left subclavian vein. So that means you are targeting the tip should be on the around of your junction of SVC and the right atrium. So if you see the different type of catheter, advantages and disadvantages in case of a peripherally inserted catheter. So it is basically high incidence of skin irritations, or it might be sometimes a dressing chain that should be weekly should be changed. So patient require assistance for that because he cannot do the dressing on his own. And however the cost is low, it can be done at the bedside, or In some cases patient on tracheostomy, in those cases we cannot put a central line or avoid a central line, so peripherally inserted catheter is advisable in those cases. In case of a central or inserted catheter, it is also single lumen or a triple lumen catheter is available. It can be inserted at bedside, relatively low cost. It can be changed over a guide wire if clinically indicated. Some cases, in some times a catheter is blocked, or any you want to change the catheter to just do a rather than putting another puncture, the guide wire can be placed and the new catheter can be railroad over that. However, this is prone for mechanical complication like difficult in some cases insertion. In some cases it might need nowadays the ultrasound is again advisable to do a centrally venous access, because to avoid any artery puncture or avoid any sort of complications, so ultrasound is again advisable to place such catheter. Multiple lumen catheter, it has advantage. However, the more number of catheter openings, again the multiple handling, the chances of sepsis is more in that way. If it is a tunnel catheter, if you see, this is more stable for long-term use. However, it is expensive. Sometimes it require a operation theater setting to put this. So that's why the care of the central line. So once the central line is placed, it must be cared properly to just avoid any septic complications, else it will again lead to some sort of the second course sore like that. So it must be the IV tubings that is utilized for your administration of fluid, that should be changed every 2 or 3 days. The catheter site, as you can see, it should be properly cleaned, scrubbed, and it should be antibiotic ointment should be applied, and dressing should be changed in specific intervals, and it should be properly fixed, as you can see in this case. In some cases you can put the date also at which date it has been the dressing has been changed. So these are very important. If you see the ward, if you go into the rounds of the ward, once your posting is there, you can see the peripherally catheter is fixed like this, or a central catheter like that. Okay, if you can see, it is this part is transparent, so that means you can see from the outside is there any redness or any swelling, anything that can be visible from the outside. So once there is something you feel there should be changed, it should be inspected closely and the site should be changed. Again, any withdrawal or administration of blood, that is for any this purpose, it should be discouraged, and always try to avoid the risk of contamination and blockage by proper flushing the catheters. Sometimes the cath flush or diluted solution of the heparin is there available to flush this catheter. Again, overall the patient on total parenteral nutrition with central catheter like this, it needs monitoring. Monitoring in the purpose of knowing any volume overload or septic complications, or might be any acid-base disturbances. Okay, once you monitor, or unless you monitor, you might miss the critical at the critical time, and you might land up in more major problem. So the vitals or hemodynamics should be monitored. Urine output is a very good indicator. It should be monitored properly, and in some cases it might decide to frequent adjustment of regarding the volume and composition. Okay, because in that way you have to change the composition. Suppose if the urine output decreasing, or if there is any change in vitals, so in that way you have to change the composition. Patient must be weighed daily, so that you can get to know regarding his sense of well-being, or any volume overload, or whether the patient is gaining weight. That again is an indicator for the nutritional advancement. Hemogram, blood urine nitrogen, liver function test, phosphate, magnesium, it should be again monitored at least twice weekly. You must monitor the sugar, that there is a regular blood sugar and urine sugar and electrolyte. This must be regularly monitored so that you can avoid any electrolyte disturbances. So the same thing, it is in tabular format, it is beautifully described in this video. So if you see the sense of well-being, that is clinical data that should be monitored daily. So any symptoms suggesting of volume overload, high or low glucose, any electrolyte imbalance, that should be monitored. So it should be at least you can, by seeing the patient, whether he is able to get in out of the bed, able to walk, or in his stair climbing. So this will give a judgment of the strength of the patient has gaining in that way. Again, the temperature, blood pressure, pulse rate, respiratory rate. These vital signs are very important to know any change in metabolic activities going on inside the body, or any inflammation, or anything disturbances that is undergoing inside the patient that can be detected. So you must also do some laboratory data intermittently to know any sort of dysfunction or electrolyte abnormality in this patient. Next, come to the complications. So any procedure or any intervention that is not out of complication, but we have to know the complication, and so that it must be vigilant, so that you can prevent those complications or avoid that complications. Okay, so by knowing the complication, you can try to prevent those things. If you say it has been divided into mechanical complication, or a metabolic, or a septic complication might also occur. So if you see the mechanical complications, because they are putting a catheter, central catheter, that's why the importance of ultrasound is there nowadays. Even though your guidelines also says that any central line, it should not be placed blindly, it must be accessed through a under ultrasound guidance, because to avoid any artery puncture. Suppose you are putting a subclavian line, so if you are puncturing a subclavian artery, if you see, this might lead to your hematoma or hemorrhage, that sometimes not able to your compression, provide compression, and also there is always chances of pneumothorax. If you see the pleura is very close, so if inadvertently the needle is placing in the lungs, it might puncture the pleura, it might lead to a pneumothorax, and also it has been seen also. So this complication has been seen very often, because if you are not vigilant or you are doing blindly, this is one of the major complications that can lead to furthermore complication. Again, the catheter might be coming out of the vein, or sometimes detached line might be dose or air embolism, fractures and tears in the catheter. So these are the mechanical complications that can be possible. If you see the metabolic complication, ETPN must be seen fluid overload or electrolyte disturbances like hyperglycemia, hypophosphatemia, hypokalemia. This should be, once you monitor the patient, you might to know this complication whether it is occurring or not. So at certain intervals you have to monitor these things and manage accordingly. If needed, supplement. So the same thing, if you are long-term TPN, you must see for the essential fatty acid deficiency, or some trace element deficiency, or iron deficiency, vitamin deficiency. In suppose in case of a liver disease or a metabolic bone disease, though you have to monitor along in that way. And lastly, the catheter sepsis infection, because if the catheter is placed for a long term, the sepsis or maintaining the proper care of the central is very important. Otherwise, the same catheter is going to induce a sepsis, okay, exit site infection. So those things have to be take care properly. So initial parts, within 72 hours, if you see infections are not because of the catheter, so in that case you have to look for the other causes. But still, if it is a persistent fever spikes even after, or just if the spike is after your parenteral nutrition administration, we always suspect infection. Okay, so it might be related to that. So in that case, you might send a blood culture in that patient. If the organism responds with staph or candida, this mostly because of the catheter sepsis, in that case you should take out the catheter as soon as possible, and also the same time send the catheter T for the culture and sensitivity, so that the appropriate antibiotic can be started. Okay, so this thing, the proper vigilance and care of the patient is very much at most required, so that it can devoid of any complications. Okay. Lastly, the misuse of TPN. That means if you are using a total parenteral nutrition, there must be a specific goal, and there is in the studies also, if it is a malnourished patient prior to surgery, there is a clear benefit if the nutrition is properly maintained, even if it is requirement of a TPN also. However, in some cases nowadays, the cancer patient or sepsis, there is studies are going on whether TPN is how much it should be continued for how long and how it should be maintained. But it should often misused in clinical practice as well. So it should be a specific goal oriented. It should not be just without any purpose. and it should not be used when the GI tract is available. So that's it. That's the AIIMS sepsis guidelines also. If you later on read those guidelines, and those always in the patient of ICU, it is enteral feeding that is promoted. Okay, as already sir has elaborated the advantage of enteral feeding. So whenever the GI tract is available, as soon as possible, the GI tract is available, ready to act, the enteral feeding should be administered as soon as possible. Okay. So I think next part is covered by your Dr. Richa. So I think we'll come at the finish this part. Yeah, sure. We just load the presentation.
No, not the first one. Yeah. Good afternoon, everyone. And today is the day when we are celebrating the day with the different names in every part of our country. So while celebrating the day and giving importance to that particular day, do not forget about the importance of nutritional management for your patient. Two topics has been assigned to me. The one is the metabolism in obesity. First I deal with that, and then I will move on to the enteral feeds available, and then different compositions and different types of feeds available for our operated patients. So while looking at the NFHS data, which has just released in, and you can see the change which reflects that there is a change in 7% obesity rise in India in last 4 years. And if you look at the pediatric population data, which says that in kids below the age of 5, there is a hike of 2.4% of obesity, overweight and obesity. So if you multiply this data with the existing population, the increasing the load of the disease burden is much higher than the expectation. We all know that obesity is like abnormal or accumulation of excessive fat, which impairs the health, and more the excessive fat, the more the risk of the impaired health would be much higher. This happens because of the molecular dysregulation of appetite and dysfunction of the carbohydrate and lipid metabolism. The adipose tissues, those store the energy, and in addition to that, that work as a endocrine organ as well. Why it's happened? That because of the decrease in ADPO-R expression level. In normal scenario, the ADPO-R expression level is normal, and that helps the maintaining the insulin sensitivity. But in obese patient, the ADPO-R expression levels has been reduced at the cellular plasma cellular level and plasma membrane level, and that reduces the sensitivity of insulin, and that enhance insulin resistance, which impaired the suppression of hepatic glucose output. In normal scenario, we all know that insulin lowers the blood glucose level. So what's happened in a normal scenario? That suppress the hepatic glucose production, and that increases the glucose uptake into the muscle and adipose tissue by the help of insulin regulated glucose transport mechanism. But in obese patient, it is down regulated all kind of obesity that affects the carbohydrate and lipid metabolism and all kind of and protein metabolism. In the skeletal muscle of obese human, the the glucose transport expression is in skeletal muscle, it is supposed to be a little normal, so more the skeletal muscle can enhance the metabolic health. Reduced glucose disposable in adipose tissue is encountered, and there are inflammatory markers which has been released from the adipose tissues that also has impact on the glucose homeostasis. So how it's work? So it affect the glucose metabolism by lipotoxicity. What's happened? The excess free fatty acids responsible for the insulin resistance, and the excess free fatty acids that enhance the hepatic glucose production, that the lipotoxicity in pancreas decreases the insulin sensitivity, and in return it increases the that affects the glucose metabolism and reduces the insulin sensitivity. That also affect the lipid metabolism. So in obese patients, what's happened, that increases the basal lipolysis by the help of increased free fatty acids. These acute phase serum amyloid A, SSAA, a lipolytic adipokines that stimulates basal lipolysis, and this works act through a CLA, which is a glycoprotein, and in the presence of extracellular signal regulating kinase signaling pathway. This stimulates the lipolysis directly, and tissue resistance to insulin mediated glucose uptake accelerates the triglyceride and hypertriglyceridemia in the patient. The postprandial lipidemia and lipemia and elevated plasma free fatty acid level recognized abnormally in all obese patients, and interaction of SAA with the HDL impairs the function of HDL and enhance the coronary artery disease risk and lower the HDL metabolism. At the protein level, also it has been noticed that the moderate level of obesity decreases the moderate level of obesity also abnormally affect the protein metabolism by increasing the rate of leucine turnover and impair the insulin antiproteolytic action. So that leads to protein catabolism. There are role of a different kind of fat deposition also on the metabolism. Like central obesity has more create more metabolic abnormalities, which is more common in the male type in comparison to the female type, which is a gluteal, femoral or peripheral depots. It increases it has tendency to increase the mortality and risk for disease, especially the disease of diabetes, hypertension or any disease related to the cardiac or cerebral or peripheral vessels. To deal with these obesity, there are two ways which is dependent on the existing guidelines which has been given by the societies, that whether these obesity should be dealt with the conventional approach or it should be dealt with the surgical means. So there are certain guidelines which has been given, and according to the BMI criteria and the existing comorbidities, the decision has been taken whether the patient should be turned over or at which side. In general, a normal overweight and obesity is always dealt with the conventional approach, which means the reduction of the calorie, restriction in the calorie, and in addition with the physical activity, and sometimes there is some medicines also added to reduce down the other comorbidities. If the BMI is over and above 35 with the other comorbidities and 40, then the person is generally considered for the bariatric surgery. So in conventional approach, there are two ways to, the society says that reduction of 500 calorie from the baseline intake, or maybe reduction of 25% from the baseline intake can help the patient. In general, it can be largely categorized for women. The calorie requirement falls between 1200 to 1400 calorie, and for male it can fall between 1400 to 1600 calorie category. This is the basic criteria, although each patient differs from each other. So before the planning, there are multiple measures which can be taken into consideration. But before I come to that slide, it is important to understand the guideline which has been given by the Society for the Asian Population, and they say that carbohydrate shouldn't range above 60% for the total calorie, and protein shouldn't be lesser than 10%, and it can vary from 10 to 20%. In certain scenario it can go little higher, but that should be well regulated. Fiber content shouldn't be lesser than 25 gram per day, which can be easily which is achievable, and total fat should not be lesser than that should not be more than 30% of total energy. Saturated fats and cholesterol also, they have given a guideline. Saturated fat should not be more than 10% of total energy, and whatever fat has been selected, it should have a good combination so that it can be incorporated in ALA, and it can maintain the optimal ratio of linoleic and alpha linoleic acid, which should fall between 5 to 10% is to 1. Trans fatty acid should not be more than 1% of total energy. MUFA, salt and cholesterol intake should also be regulated well before planning a diet for the obese patients. So there are many studies which has been done in past, and these all studies has one conclusive idea that whatever the diet is, like it should be calorie restricted. Whether the composition says that the fat percentage should be little higher than the normal, or maybe protein should be higher in normal, or it should be combination Mediterranean, Atkins, or any fancy diet. The result is almost same after a year, or maybe after 2 years. The range falls between 3 to 8 kg weight loss after a year, and after 2 years the range that range falls somewhere between 3 to 5 kg. Dietary assessment is important before planning diet for the patient, which it is important to take care of the lifestyle pattern, eating habits, eating disorders, pre-existing nutritional deficiency, any existing comorbidities, or any, and based on these all, the realistic goal should be set for the patient. Whatever diet has been selected for the patient, it must support the 5 to 10% of weight loss in another 3 to 6 months, and that should be synchronized well with the selected treatment line. Glucose monitoring is equally important, and monitoring and patient understanding about the diet is equally important. So patient must be called for the multiple interaction with the nutritionist and the treating team. If patient goes towards the bariatric side, then pre-op surgery, the management and the planning is similar to the conventional approach. Just 15 days prior to surgery, patient put on the liquid diet to give some degree of weight loss, minimize the impact of the existing comorbidities, and to assess the compliance of the patient with the next line of nutritional treatment. After the surgery, soon after the surgery, the next day the patient put on a clear liquid diet. Why clear liquid diet on a first day? To assess whether there shouldn't be a leak or any other complication associated with the surgery. And once the patient is adjusted with a clear fluid diet, it is important to put patient on a full liquid diet and keep an eye on a patient hydration. That is a mandatory thing. Within a week, patient put on a pure diet, and then to the diet progressed to the semi diet, and that to be then to the normal diet. The bariatric surgery has 3 different procedures, and each procedure may differ with it. Each procedure may require a different timeline to progress from one diet to the another. There is no hard and fast rule that one diet should be progressed to the another as per the timeline. Each patient is different, so after the complete assessment, the diet should be progressed to the next level for the keeping patient safety into consideration. Exercise and physical activity guideline has been given by the NIN, which is for the normal people and for the weight reduction, that says that at least anybody who is above the 20 years of age, they must do a minimum of 30 to 45 minutes of exercise for all 5 to 6 days. Moderate intensity can be done for 5 to 6 days, which means 5 to 6 kilometers per hour. Greater the activity would have the better impact on the other comorbidities, improvement in the comorbidities, and the better result in the weight loss. Exercise program must include warm up and cool down period that should be conveyed to the patient, and during exercise the intensity of exercise should ensure 60 to 70% rise in the heart rate. To summarize this all, it is important to understand that excessive fat has accumulation has health as a hazard, and molecular regulation of appetite, lipid and carbohydrate metabolism dysfunction leads to atherosclerosis and triglyceridemia, so obesity shouldn't be taken lightly. Energy store that acts as an energy storage organ, but it is also work as a endocrine organ, and it produces multiple many modulates, and that has direct impact on the metabolic process in the body. Treatment approach depends on the severity and the expected outcome. So the treatment approach should be given as a treatment module, and it should be well explained to the patient. Now I am moving to the next topic, which has been already dealt with the both the doctors, and I would deal exclusively with the different feeds available, and why the particular feed should be selected for the particular patient. So nutritional therapy is important, and it has the therapeutic intent. Before approaching to the therapeutic nutritional therapy, it is important to understand that what are our goals, whether we are going to treat the malnourished patient, or the patient is well nourished. The patient is what are the nutritional requirement of the patient, what is the nutritional route which has been opted for the patient, is it an exclusive meal or it's a combination, it should be taken into consideration. Disease related modification is required or not, immune modulating nutrition needed or not, is it patient tolerating the feed, or what is the glycemic control, is it adequate or it's require additional care. So before selecting the formula, which formula should be selected for the patient, it is important to understand the functional status of GI tract that is going to affect directly these feed selection. The physical property of formulas: osmolality, fiber content, density, viscosity, micronutrient ratio, digestion and absorption capability of the patient, a specific metabolic need if at all it is needed to taken into consideration, contribution of feed to fluid and electrolyte needs or restriction. That is very important to understand. Whosoever got posting in the ICU, they can understand these things much better. This line, that fluid restriction is very, very important before you plan or select any kind of formulation for your patient. We all are Indian, and we believe in cost effectiveness in everything, especially when it comes to the therapeutic nutrition, that the cost comes the first into mind. So cost effectiveness is equally important before planning. Feeding tubes, the size of feeding tube and type of feeding tubes is equally important to taken into consideration. This has been dealt earlier, so I will not go in detail. Broadly, if I have to classify the entire range of the formulation, enteral formulation, I can categorize into two. One is the commercial, and another one is hospital or homemade feed. The commercial is like always available in the packaged form. In India, it is only available in the like mainly available in the powdered form, but in abroad it is available in the liquid formulation where it can be hanged directly and attached to the feeding tube to the patient. It is more sterile, less risk of contamination, longer hang time, exact composition can be achieved and a little expensive. While the hospital and homemade feed, it should be prepared daily and it should be according to the time. Sterile, not so, and more risk of contamination here. Because it is prepared by the human, so the risk of contamination is much higher. More monitoring is required. It has little shorter hang time, so the preparation would be multiple times required in a day. The composition can be adequate or it may be little variable, and it is more affordable in comparison to the commercial. There are range of commercial supplements available in the market with different name. What should be known is like the one is polymeric, which is always considered as a complete balanced formula. The another one is peptide based semi-elemental formula. The another one is meant for the renal patient, dialysis patient, which is disease specific, and diabetic. The whole range of diabetic formulation available in the market, which is meant for the diabetic patient, which is sucrose free. And immune enhancing supplements are also available, which we generally keep in the category of the modular nutrition. So a standard formula, which is more common in for most of the patient, it is like it provides somewhere between 0.8 to 1 kilocalorie. In general, 1 kilocalorie per ml. Protein content, approximate 40 gram protein can be achieved with 1000 ml of volume. Lipid, that falls somewhere between more or less 30% of total calorie, and mainly the lipid is available in the long chain fatty acid. Non-protein calorie ratio is maintained somewhere between like 150, which is appropriate for the critically ill patient, and it is isotonic, and essential vitamins and micronutrients available in it, but in a very minimal quantity. Semi-elemental formula, which is also a complete nutrition, but it is present in a pre-digested form, and mainly the protein is available in the complete hydrolyzed, either in the amino acid form or dipeptide. Generally the dipeptide, the chains are available in it, and carbohydrate available in the simpler form, easily digestible form. Fats, major portion of fat is in MCT form, and it is indicated for the major GI tract diseases like ulcerative colitis, or maybe malabsorption, short bowel syndrome, fistula, lymphatic disorders, and intolerance to standard feed. Disease specific formula may fall between 1 to 2 kilocalorie per ml, and patient require volume or electrolyte restriction, or maybe sucrose restrictions. There are hepatic formula also available, which is earlier it was thought of the best product for the liver disease patient, but now it is mainly used in the hepatic encephalopathy, because the normal formulation do have the branch and amino acid available in it. Modular nutrient, the composition of critical items such as it could be just protein, it could be just immunonutrition, it could be just sodium or potassium or fat content. So there are multiple range available. High protein supplements that range between 60 to 90% of protein content in it. Carbohydrate, either it could be nil or very less quantity. It is available in concentrate, hydrolyzed or isolate form, or it could be a combination of all. Pure MCT is also available in a pure MCT with the name of pure MCT, which is a medium chain triglyceride, and it is derived from the coconut or palm kernel oils. Dietary fiber is also available in the market, which can be utilized for the patient who has a high output fistula, that can be added in the formulation, and it has different health benefits. You all know that it has a gastrointestinal motility and relieve constipation. It increases the stool volume, absorb water. So, and it does have some good impact on the comorbidities like diabetes and heart disease or hypertension. Then we have a whole range of hospital based formulas. Since you all are in AIIMS, and you know that AIIMS has a huge dietetics department which prepares their patients' feed at house level, and we have a different range which starts from the half strength milk to full strength to a special to modified to disease specific, and then there are many. Whatever I have shown in this one slide is just a glimpse of giving you option that these are the options available. Then each patient is different, and while after taking round, the each feed can be modulated or modified according to the patient's personal need. So half strength milk is just a milk which has been diluted with the exact quantity of the water, just to assess whether the patient is comfortable to have to initiate the feed or not. Full strength, it is just a milk, nothing else. A special feed, or the you can call this feed a special feed as a high calorie high protein feed, which the intent of calling is special because it has the special ingredients additional ingredients in it to give sufficient quantity of protein and the calorie. The disease specific range has many things, which can be a diabetic where the no sucrose and the other products are available. The renal feeds, that is low in electrolytes, and it is modulated according to the fluid restriction. And hepatic feeds, generally we don't provide to the liver patients, but then again, if at all it is required, it is basically prepared with the help of pulses, and the additional liver related supplements can be added in it. So the special feed or modified feed or high calorie high protein feed of 500 ml of institute feed can provide 1.2 kilocalorie per ml, which means somewhere between 600 calorie in 500 ml bottle, approximate 45 gram of protein through 1000 ml, which is 18% of calorie, and fat approximate more or less 30%. Fluid content, free fluid content is approximate 80% in it. This feed lacks in water soluble vitamins, B complex, ascorbic acid, iron, sodium. So supplementation is required if your patient is going to be on a enteral feed for a longer duration and on a hospital feed. And the modification can be done according to the patient's requirement. This is just a method, and the ingredients I put what all has been put for the patient. Any supplement, and milk, sugar, oil, egg, partially cooked egg, and the corn starch to give sufficient to provide sufficient carbohydrate. Immune modulating diet has definite impact on the patient health, that decreases the infection, ventilator days, that decreases the length of stay. These all are well documented in the studies, but no change in the mortality has been seen with the addition of immune modulating diets in the patient. These are available with the different names, like arginine, glutamine, nucleic acid, omega-3 fatty acids. Antioxidants are also available, selenium, ascorbic acid, and vitamin E. The most common one is the glutamine, and the beneficial impact has been seen in the burn, trauma, and mixed ICU patient. Dosing varies between 0.3 to 0.5 gram per kg of per day. And this is available in the powder form with the antioxidant, and it is frank as a glutamine also available with a different company. The micronutrients, selenium does have some good impact on the in the sepsis patient, and that meta-analysis says that it significantly reduced the mortality with high doses of selenium. And zinc, it has some innate immune suppression, and this reduces the risk of secondary infection. Vitamin A, C, and E act as an antioxidant. Patients who are on enteral nutrition, they do require micronutrient, vitamins, and trace elements in a sufficient quantity. This is just a table to understand that these are the supplements which are required, and these all lack in the hospital-based feed. Enteral feeding has multiple level of complications. Sir has already dealt with it, but I would like to address the one complication, which is the diarrhea. The incidence of diarrhea varies between 15 to 18% between the patient who are on enteral feed. The most episodes are self-limiting, and the reason for the diarrhea is not always feed. Most of the time PPI and antibiotic. Hyperosmolar feed could be one of the reasons, so it is important to plan feed accordingly. And infection could be also a reason for the diarrhea that can be assessed by various means, but to treat with the feeding modules, it is important to titrate the feed in terms of volume, in terms of consistency, in terms of micronutrient composition, and adding of a soluble fiber which is available in the Indian market with different fiber names. Benifiber fiber, and the recent one is the Pentasure fiber is available also in the market. And sometimes just modifying the reducing the lactose content in the feed can help the patient, and no further modification might be required. So, but do not try to withhold the feed unless or until it is absolute contraindication for that. To summarize that, I would like to call Sir to summarize the entire session. Thank you.
लास्ट
हाँ उससे पहले एक मिनट
Okay, late in the evening, I see there are still a lot of warriors left going through the seminar today. Thank you very much for being with us, and it has been a pleasure. Now I'm just going to raise a few points to summarize that. Now again, nutritional support is indicated in severe stress or sepsis, and cannot maintain, where the patient cannot maintain adequate caloric intake for more than a week, then we should consider how to support him. In stress, patient should receive about 30 to 35 non-protein calories per kg body weight, and in non-stressed patients should receive about 25 to 30. 1.5 to 2.5 grams of protein is what is required per kg per day. Patients on prolonged enteral and parenteral nutrition will need supplemental vitamins and minerals. Remember, enteral nutrition is the preferred mode of nutritional support and should be used whenever it is possible. Patient who is receiving TPN should be monitored every day for volume overload, electrolyte disturbances, and septic complications. Okay, now you are not going to win 1 crore rupees if you answer these questions, but this is just to arouse your interest. I think you can try a few of them later. Now I also wish to thank all of you who have been here, who have listened to us, and I think I am delighted that so many people have remained through the lecture with us. Now the slides are available with us. The class representative can contact us anytime, take it from us and distribute it among all the resident doctors. Now major portions of the presentations today we have taken from a chapter which we have written for you only. It's from Essentials of Surgery, chapter 6, chapter on clinical nutrition. Now it is there with me. I do not know how to deliver across to you through this medium, but you people, any one of you can approach me in my office and we will hand it over to you. Okay, then I see that all of you would be interested in going for a nutritional break. So I think on behalf of all, Dr. Bhoi and Dr. Richa, I must thank all of you for being with us. Thank you so much. ठीक है, thank you.
Thank you, sir. We are on time. मेरे पास 2 to 4 and 2 to 4 पे over हो गया.
अच्छा, ये इसको निकालना पड़ेगा ना.
हाँ जी सर, मैं निकाल लेती
इनको डिलीट कर दीजिए ना, ये यहाँ से ना इनको डिलीट कर दीजिए. Otherwise it will just clog this computer. Okay, I think next year again at this time we'll be having this seminar. So I will suggest कि in the month of November ना,
जी.
पहले आप एडिट करिए.
अच्छा ओके.
सारों को कंबाइन करके फिर उसके बाद आप एडिट करिए.
जी.
Somewhere around 14th 15th of November we can meet for a few minutes and we'll have to reduce it. Let's make it about
1 hour.
1 hour 30 minutes.
ठीक है सर.
So
ठीक
we'll
है
try
सर.
to make it
ठीक है.
because now we have seen that what all these
एक्चुअली
questions-
काफ़ी सारी चीज़ें जो है ओवरलैपिंग है.
I think about 25 slides have overlapped. No? So we can cut it off. No? And we'll have to stick to only that slides content. No? So we'll
ठीक
do
है.
that.
So should I shut it down?
हाँ, वो
ठीक.
hand over करेंगे.
हाँ जी बस वो आप अपना पहले ही ले लीजिए.
हाँ मैंने ले लिया.
हाँ, क्योंकि नेक्स्ट क्लास हो जाए.
अच्छा.
ओके बस ओके.
Thank you, Dr. Rishabh.
हेलो. हाँ बोलो. हाँ क्या हुआ? क्या हुआ? मैं तो रात से हुआ है ना वो सबसे लोगों से. हेलो मैं बोल रहा हूँ. अच्छा अभी करके गए? तुमने कंप्लेन कराई थी क्या अभी? खाली कर रहे हैं वो उसको साफ करके दें उसको. वहाँ पर वापस चले जाओ, अभी एक घंटे अभी जाते हैं वो साथ ही पकड़ लो, उसमें सारा पानी तक कर रहेगा ऊपर। हाँ फोन ना उठा रहे वो वहाँ पे, वो फोन उठाते ही नहीं, बदमाशी करते हैं वो। मतलब ये सारा करते हैं, उनके सारा